सर आई थिंक श्रेनिक सर का ना नेटवर्क इशू है। आई एम
Sure.
कॉलिंग। हाँ, वो शायद लेफ्ट हो गया है। मैं उनसे कोऑर्डिनेट कर रही हूँ।
Perfect. So please just let me know when I'm supposed to start and I will start.
श्योर सर। सर श्रेनिक सर हैज जॉइंड।
Hello, sir. So am I audible loud and clear?
Hello, uh, am I audible?
Yes, sir.
Uh, Unfortunately, I'm having quite some technical issue, network issue, and I'm rather getting disconnected.
Right.
All right. Good evening, friends. I'm Shrenik, Mr. President, Ambassador of Indian Cancer Society Study, and very warm welcome to everyone to Friday's with Shrenik live webinar today, and we are having esteemed guest Dr. Devendra Parik from Ahmedabad. He is a thoracic uh, robotic cancer surgeon, and he is also guiding students, for performing robotic surgery. Very warm welcome, Dr. Your talk, and you can also share your slide, Sneha. Please allow the screen sharing.
Thank you, Shrenik bhai, for such a wonderful opportunity. I'm glad to be part of this webinar. And now I would like to start sharing my screen. Please let me know if my screen is visible.
यस सर इट इज।
Perfect. So, topic for today's discussion is role of robotic surgery in thoracic cancer. And as sir said, I am a surgical oncologist who is focused on doing thoracic surgery, and my prime focus is robotic assisted surgery uh, in most of the cancers whenever it's possible. So today, in brief, we will talk about what is thoracic cancer and why robotic surgery is very important when we talk about thoracic cancers. So, first and foremost, whenever we talk about cancer and its treatment, especially about surgery, बहुत important हमारे लिए यह है जानना कि we are talking about two form of safety. One is oncological safety, where we are certain about principles of cancer treatment, where we are taking out the cancer 100% out of the body by doing performing surgery. Second, and most important from patient perspective is surgical safety. That is a very good recovery with lesser blood loss, lesser disturbance of patient's physiology, and early resumption of patient's routine activity. So when these two aims are there in treatment, we need to evolve. We need to have certain amount of developments throughout our surgical treatment, which will lead us to these two safeties. And there comes the role of advances like robotic surgery. If you can see this slide, we are seeing tectonic shift in the treatment of thoracic cancer surgery. On the leftmost part, we can see this big scar, a big opening of the chest wall, and then comes the smaller scar, and then comes the robotic surgery. So, with this slide in mind, we'll talk about today's robotic surgery in thoracic cancer. And when I say thoracic surgery, it encompasses four major components: esophageal cancer, lung cancer, mediastinal masses like thymomas, intermediastinal schwannomas, postermediastinal schwannomas, neuromas, and uh, then chest wall tumors. And we will try and find out where actually robotic surgery can be helpful and what are the benefits of robotic surgery in thoracic cancers. Just to can you hear me?
Yes, sir, we can hear you.
So these are the two ways we can perform the thoracic surgery. Left is the video assisted thoracoscopic surgery and right is the robotic assisted surgery where surgeon is sitting on the console. So this is how a surgical robot will look like. Whenever we talk about robotic surgery, there is a conception in general population's mind that a surgery will be performed by a robot. That is not the case. Surgical robot is an advanced surgical system where there are three major components as we can see here. One is patient card which stays with the patient, then one is the surgeon console on the rightmost where surgeon sits and performs the surgery, and then third one is the vision card which houses the vision card and all the energy devices and other I'll say it's a central processing unit of the robot. So when we say robotic surgery, we have to understand that we are not talking about something which has some autonomous activity. Today, surgical robot has zero autonomous works. 100% of the surgery is performed by surgeon himself and controlled also by surgeon. So this is a small video demonstrating how it works in real time when it's inside the OR. These are how surgeon's arm works. This is the console where surgeon sits, see through the console view and perform the surgery with this joystick. Can you see this joystick which is hold by surgeon and perform at the time of surgery like this we are seeing here in this video. And in real time when surgeon moves his arm inside the thoracic cavity, robotic instrument moves, and this is how it moves. This robotic instrument has very similar to our hand wristed instruments. So similar to person's wrist, these instruments can move inside the cavity and perform the activity with great precision and reach. We have to understand that when we talk about the thoracic cavity, it's a small cavity and lot of important structures are there like heart, lung, then major vessels like aorta, IVC, SVC, and then apart from those structures, we have to make sure that we are dealing with a cancer and very precisely we need to take that cancer out without disturbing or injuring any important structure. So that is the situation where robotic surgery play a very crucial role because of these three distinct advantages. So what are these three distinct advantages? One is vision. When we talk about robotic vision, it has immersive 3D camera which has magnification going up to 10x. And beautiful part about this magnification is that it's a surgeon controlled magnification. Surgeon can actually zoom in and zoom out, increase the magnification according to the need and requirement. Second important thing is the instrumentation. As I said, these are wristed instrument with 7 degree of movement. Even our wrist has a limitation, but robotic instrument has very great dexterity. So it can move significantly and reach to every single nook and corner of the thoracic cavity. And you can see the comparison of size, they are very tiny at the tip. So it can actually aid in the precision of our work. And third and most important thing is that tremor filtration. So unlike human hand, robotic instrument does not feel the tremor, they are filtered by the technology. So this precision, vision and reach uh, increases the safety when we perform this surgery. So these are the some of the advantages of the robotic surgery. uh, Latest robotic surgery system is the Da Vinci Xi system, which is available now in India for last uh, 15 years. And this system is not new. As we are talking about this system, we must understand that this is in clinical practice for last 25 years. And in India, it has been for last 15 years. And now there are extraordinary surgeons performing these robotic surgeries in most of the surgeries possible. And bigger the surgery, higher the advantages of this robotic surgery. When we talk about thoracic surgery, esophagus and lung makes predominant volume of the thoracic cancer surgery. Apart from that, mediastinal masses, as I mentioned, some chest wall tumors and tracheal masses, uh, we can take help of robotic surgery. And I like to show very specific situations where robot can be helpful, like esophageal cancer surgery. Now, esophageal cancer surgery is something where every patient receives chemotherapy or radiation or combination of chemo radiation before the surgery. So surgery becomes little bit trickier. And there comes the role of robotic surgery for esophagectomies. Why it helps? Because there is a precision dissection along the airway and the recurrent laryngeal nerve. I'll show you in a moment that when we talk about esophageal cancer surgery, we work very close to the airways and the nerves and the heart. And when we are working in such close proximity to the important structures, we have to make sure that every single structure remain untouched. And there comes the role of precision surgery. Again, it reduces the trauma, decrease blood loss, decrease pain, decrease hospital stay. I'll say as a cancer surgeon that better surgery and safe procedure is the mainstay of technology. These all possible advantages like decreased blood loss or hospital stay or pain is a byproduct. As we know, esophagus is something which starts from the neck and goes right up to the abdominal cavity. And that's why in esophageal cancer surgery, we have to operate in all three areas, chest, abdomen, and the neck. And we also need to do the reconstruction. And this is just a small demonstration of how things work. See, there is a important structure like this blue structure which is enhancing. And when we are working along the esophagus, we need to be sure that we don't hit anything which is not supposed to be touched. That's a thoracic duct. If we touch and injure that small tiny structure, it can give rise to great post-operative morbidity and problem to the patient. But precision work performed by robotic surgery and
This
its
meeting is being
small
recorded.
instruments can actually help us. And as we know, these technologies can bring lot of other advances and benefits. These are the ICG guided surgery. So as we are seeing here, we can actually see where is the important structure to be safeguarded, and we can precisely go between that important structure and esophagus. So that is one advantage. Another advantage of robotic surgery is these staplers. Earlier, we were taking sutures for all the surgeries, whether we were doing anastomosis, whether we are doing conduit preparation. In esophageal cancer surgery, we need to prepare a conduit from the stomach, which will replace the resected esophagus and get anastomos with the proximal cut end of the esophagus. And now this step is done performed with these short form staplers, which are extraordinary and very safe innovations, I will say. And I'm very happy to see them. We started doing this with short form in 2021, and it has actually changed the outcome of our patients. And once these are stitched, they can simply transport it to the neck or thorax by simply pulling. And as you can see here, because of the registered instrumentation of the robotic technology, registered arm, suturing and all other maneuvering becomes so easy and effortless, as if we are sitting inside the cavity and performing the surgery. See, this is the food pipe we are putting at the end of this procedure. So I'll not go in detail of these steps, but just to say, these are some of the advantages which actually excite surgeon like us in performing this surgery, and uh, ultimate benefit is translated to the patient. This is another advantage of robotic assisted surgery. These are the important nerves, which is recurrent laryngeal nerves. We need to preserve this nerve, and because of this intraoperative nerve monitoring integrated with robotic arm, we can safely dissect along the nerve, safeguard the nerve, and at the same time clear the lymph node along the nerve. This is the windpipe airway, as I was talking about. See how closely we are working to all the important structure, be it a nerve or pericardium or the major vessels or the windpipe. So this is the important of robotic surgery. Uh, this is again esophagectomy. This structure is the esophagus, and this is the beating heart. We can see the heart, and we can go absolutely in between. Every single fiber can be visualized so nicely. Every lymph node is taken with the specimen, and as you can see, magnification works wonder. Uh, we cannot skip or miss anything, and that safety is not for patient or surgeon, it's for the overall science and its outcome. So many a times we talk about patient's benefit or surgeon's benefit, but here we are talking about a best way we can perform or execute the scientific procedure. And like all other evolution, everywhere when there is a excessive safety, then only we can talk about the efficacy. I mean that whenever there is a very safe procedures, then only we can actually know how efficacious or useful it is for the patient. So this is about the esophagectomy, how nicely we are taking the lymph node from the airway. This is the left bronchus just mentioned. I'll not go in detail again, I'll skip this video. Then comes the anastomotic part. See, when we are anastomoting the esophagus with the stomach in the esophagectomy, this is the gastric conduit, as we discussed. How nicely we can evaluate the blood supply. This is the one of the advantage of the ICG. We can actually evaluate the perfusion, these blood vessels going inside the stomach, and we can make sure that this stomach is very well perfused, well vascularized, and if we can anastomosis very nicely with the upper curtain of the esophagus, then it will be certainly a safe. Again, help of sure form will increase the safety, decreases the time. This is 3-row staple based side to side esophagogastric anastomosis performed during the esophagectomy. We pass a rice tube and finish the anastomosis. This is at the end. And very important to know that at the end of these procedures, tiny incisions will be there just to take out the specimen. Otherwise, 8 holes, that's it. And because of this technology, we can now standardize these procedures. These were considered one of the major procedures with almost 20 to 30% worse outcome in terms of mortality. But now, because of this great technology in esophagectomy, life-threatening events are happen only in 1 to 2% of the cases. So safety of the procedure has gone significantly. Now we talk about the lung cancer. Lung cancer is one of the most common cancer worldwide, and it is again one of the most common cause of death because of cancer. So, and if detected early, surgery is the best chance of the patient to get cured. So this is one cancer we shall not take lightly. Robotic surgery again is a game changer. As you can see here, small 8 holes, and that's it. Specimen is taken out from another 4 or 5 centimeter incision, and this is how it looks like when we are inside the OR. This is how our OR setup will look like when we are performing robotic assisted lung surgery. And as I said, many of the advantages are self-explanatory. See the vessels, these are major pulmonary vessels, and when we are doing lung surgery or resecting the part of lung, we have to deal with such major vessels. If they bleed, it bleed torrentially, and they are directly coming from the heart. So it's a very troublesome bleeding. But because of good technology, uh, things has become so safe. Because of this wristed instrument, because of these staplers, we can now simply take these vessels with great safety, and reproducibility. So it is not about one procedure, it is about doing same procedure again and again and again and producing the same outcome, so that patient will have faith on the doctor. Even doctor or hospital will have faith on themselves that okay, we'll be able to treat this major surgery with great efficacies and safety. So as you can see here, everything can be taken very swiftly. Again, same thing, we will not go in detail. Challenge is even more when we are talking about small lesions like 6 mm, 8 mm, 10 mm, where doing biopsy or locating the lesion itself becomes challenging. Those are the areas where ICG comes of great help. So here is a small lesion of 7 8 mm, barely visible, but we have taken help of ICG which has illuminated the vision, and because of that illuminated vision we can actually take out that entire lesion. Now we are taking out that lesion with the sure form staplers. So in real time we can evaluate where is our lesion by locating it with the ICG and then take help of sure form staplers to resect that area. So these are some of the great advantages. uh, Previously we were very hesitant to perform this procedure because there were instances where we were not able to define or locate the lesion, but now we are confident when we talk about the robotics in thoracic cancers. Another important area is the mediastinal masses. So mediastinum is the area of chest where it's between heart and the chest cavity and in between the lungs. And there are certain masses like thymomas. It can be as small as 4 5 centimeter or as big as 10 12 centimeter, and all these masses now can safely be taken out with the robotics. Even germ cell tumors, we know Yuvraj Singh, he was suffering, he has in 2011 suffered from germ cell tumor. When these germ cell tumors are there, they are again situated in the mediastinum very close to the heart, and again robotic is a great help. Only incision we need to put is just to take out that mass. But if that mass is 4 centimeter, then 4 centimeter incision. If that mass is 12 centimeter, then 12 centimeter incision. That's the only incision we need to put. Otherwise rest everything can be done with this extraordinary technology. See this such big lesion taken out just above the heart. We can see the pulsating heart after taking out the lesion. That's the beauty of robotic surgery. On the left we can take out the mass in real time and see underlying heart and the major vessels. Again very important lesion, parathyroid adenoma. Parathyroid adenoma are small functional endocrine lesions which can derange our calcium and bone health and the other metabolic parameters, and many a times they are situated inside the thoracic cavity and they are so small or tiny that it is challenge to locate them. But because of great technology, as I mentioned, ICG, see this lesion, 1 centimeter lesion and mixed with the fat density. So it is very difficult to identify whether it's a fat or parathyroid adenoma. But because of this ICG and extraordinary robotic technology, we can define the lesion, take it out safely, and we can be sure that we have correctly taken out the lesion in the anteromediastinum. Again a tracheal lesion. So trachea is a windpipe which is situated in center of the thoracic cavity, and whenever there is a lesion, it's a big challenge for treating surgeon and all the physicians involved in the treatment. But now with the help of robotic assisted surgery with very small 8 mm incisions, we can actually dissect, cut, take out the lesion, repair the trachea again, and that's it. And patient has such wonderful recovery that we cannot think of. So then certainly the question that all thoracic cancer be treated with robotic surgery? Answer is no. We have not reached there yet. I hope that eventually we will reach there, and probably in future all the thoracic cases will be treated with the robotic surgery. But today there are certain limitations like this case where there is a very big mass of almost 25 30 centimeter. Certainly it cannot be dealt with robotic surgery. We need to put an incision, do a thoracotomy, and take that lesion out of the body. So there are certain limitations as of now. Apart from those limitations, there are other limitations like it's a little bit costlier technology, patient have to pay, and learning is again steep. At our center we have done around 2800 cases. Thoracic cancer surgery is third most commonly performed surgery at our center. as I mentioned, there are certain benefit to the surgeon. Surgeon can sit very comfortably at the console and use four robotic arms. So imagine a situation where a two-handed surgeon can control four instruments. It can enhance his or her ability by almost 2x. Very clear vision, and then integrated interoperative nerve monitoring or ICG or Firefly technology or sure form staplers, which can enhance the safety and efficacy of the surgery. Conversion has now become absolute seldom is situation in thoracic surgeries. Whenever we are performing robotic assisted thoracic surgeries, we certainly try and finish the procedure the very way we have defined or explained to the patient, and that's one of the very important thing for us as we are working or playing or making sure that our patient's safety remains unperturbed. Patients' advantage are certainly manifolds. They have very quick recovery. They have extraordinary treatment with very little derangement of the physiology. They return to their quality of life within no time. Most of the patients get discharged between third to fifth post-operative day. And in cancer, it is also very important because most of the cancer patients do need to receive some form of adjuvant treatment as well. So if there is a early recovery after surgery, then they will be able to receive their adjuvant treatment in timely manner, and that also will increase the safety in terms of their cancer related outcome. There are certain challenges with robotic technology, monopolistic platform, very few players, and because of that they charge heavily. There will be some future studies to compare the safety and cost and the learning curve. Training pathways are very tedious. Need to build a team when we talk about robotic and such major complex surgeries. But at the end, I will certainly say that it's a best form of surgery. It is going to shift the paradigm in very big way. Every surgeon must embrace this technology. Every patient must ask their treating doctor about this technology and their implications. And this is the fantastic team which enabled me to perform this extraordinary surgery at my center, which is HCG Asta Cancer Center, Ahmedabad. And I always end my slide with saying this: everyone is most welcome to visit our center and have a test drive on what is robotic surgery. And thank you very much.
Thank you. Friends, I'm extremely sorry. I had kind of a technical issue, and I
I'll be
was,
very happy to answer if there are any questions.
uh, yes, give me a minute, and
Uh,
we will.
Shrenik,
Am I
yes, please. Yes, yes, now
am
you
I
are
audible?
audible, sir. Yes, yes, yes.
Super, super. Thank you. Friends, I'm extremely sorry. I mean, I was having kind of some technical issue, and we will proceed with Q&A. Dr. Parik, before we proceed, I would like to have some conversation with the audience. uh, Friends, you know, HCG at the Cancer Center, that is my second home for last more than 25 years. And I would say more than 95% of the oncologists and individuals, they know me personally. And I rather enjoy inviting them to our live webinars. Now, uh, see, basically, I am trying to bring the best of the best oncologists, for their knowledge, expertise, and experience sharing. And these are the knowledge, experience, expertise. You won't be at all able to find it on a Google or on a web browser if you keep on browsing. So this is kind of a real time knowledge sharing by the experts. Now, in case of Dr. Parekh, is having more than 15 years of experience as a robotic surgeon, and he has very profoundly explained everything about uh, with the pictures and everything live. Now, Dr. Parekh, I would like to emphasize, of course, you already explained, but for our audience and also those who are watching on YouTube, I would like to give a few minutes once again on robotic assisted surgery, because what happens is there is a myth among patients, caregivers, that robotic means it is done by robot. As a matter of fact, this is done by surgeon himself or herself. So that is what I want you to explain once again in a brief.
Very, very important point. This is the very common question asked by most of our patients who visits us, that whether the procedure will be performed by robot himself or by surgeon. So today I will re-emphasize this fact again, that even though name is robotic surgery, it's a advanced surgical platform where everything is performed and controlled by surgeon. So unlike conventional surgery where surgeon take the instrument in his hand and perform the surgery, in this platform instruments are held by robotic arm, but that arms are controlled by surgeon is sitting on the console, holding that joystick which we saw in a video and performing the procedure, but there is zero automation. So the moment surgeon stops, robot stops. And here advantage of the surgeon is that he has four instrument to control. He has better degree of freedom when he is using the robotic instrument by joystick. There is no locking. So if we see our hand, there is a locking. So now beyond this, my wrist cannot go. But robotic instrument certainly has that freedom of movement. So every nook and corner, the robotic instrument will be able to reach, and that actually enhance the safety. We are talking about a surgeries where we need to go in very close proximity to the major structures like heart, like the windpipe, like the major vessels, and then take out the lymph nodes or cancer harvesting basins. And if we able to do things very precisely, then certainly it will translate into the benefit of the patient in terms of better cancer control. So yes, I'll re-emphasize, surgery is performed by the surgeon and not the robot, but robot has a great help. So it's a duo, a robot plus surgeon makes an extraordinary team, I'll say.
Thank you. One more point for the audience. You know, these days, a lot is being talked about AI, that is artificial intelligence. But my dear friends, let me explain, or rather, let me emphasize, as Dr. Konik has said, a robot alone cannot perform surgery, right? And here, the experience, knowledge, expertise, years of performing surgeries by surgeons like Dr. Parikh and too many, that matters. So, I mean, I'm not against AI, but yes, human intelligence is at the top, and AI is one step down. And that one, I have rather chosen to invite Dr. Parikh to speak about robotic surgery or other robotic assisted surgery. Let me open the platform for questions by individuals and audience. So yeah, whoever is willing to ask question.
Can I ask a question, Mr. Shrenik?
Please, ma'am.
Yeah.
Yes, please,
Yeah,
please.
thank you, Dr. Parikh. Your talk was very interesting, and the videos were really amazing. I felt as I
Thank
was
you.
inside the OT, and I think your board behind you, "Impossible is possible," is really sums up the whole message that we never thought there would be robotic surgery in India, and I think it is possible now. I just have two
Yes.
questions, and that is, what is the cost of this robotic surgery? Is that something affordable by the common man?
So I'll say 7 or 8 years before this time, in 1917, 1918, there was a lot of hype related to the cost of the robotic surgery. In actual term, I'll say it's around 70 to 80,000 costlier than conventional surgery. But earlier that number was looking big. But post COVID era, if we see, that number has gone down significantly. We have experienced that in COVID. even for a simple infection where patient required ICU care for 5 days or 7 days, bill were going in upward of 4 to 5 lakh rupees. And here we are talking about a surgery which is a supra major surgery. If there is any untoward event happening during or after surgery in terms of surgical safety, certainly that patient is going to visit the ICU again, or stay in the hospital for a couple of more days, and that will nullify the that extra cost which we pay for that robotic technology. Second and most important thing is, as we talk about this impossible as possible, this is again given to me by one of my patient. She is a 89-year lady, very elderly, frail patient. We operated her on robotic platform for esophageectomy. Now, we all know as a clinician that with increasing age, safety is a much more challenging, or I'll say very complex equation. And many a time patients are afraid of surgery. Even doctors are afraid of performing major surgery in very frail and elderly patient. But because of the extraordinary technology, now increasingly we are taking more and more elderly patient for our uh, complex cases. So that says it all. I am of a strong opinion that at the end of the day, center point of all treatment is safety. Everything revolves around the safety of the patient. Certainly, we are living in a country where economics play a very major role. But if we see the cost benefit ratio, it certainly is shifting towards the, so that pendulum is shifting towards the robotic surgery.
Right, right. The second question was that, you listed the advantages of robotic surgery. Now, you said it was all started 15 years, since 15
In
years
India,
robotic.
in
Yeah,
India,
in,
India.
yeah, in India.
Yes, yes, yes.
So now, when you look at the list of advantages, so 15 years before, were some of these advantages or some mistakes that were made at that time, has it been rectified by robotic surgery? And were there a lot of casualties without robotic surgery 15 years before?
Yes. So I'll put it in this way that as a surgeon community, we are learning. So if we see the result of 1990s, they were different than what we were seeing in 2000. And now results of 2020 or 25 are stark different than what we were seeing in 2000. So every 2 decades, we are seeing extraordinary shift in safety of the surgical outcomes. And robot has certainly played a major role. So in most of the robotics, so I'll give you again. So I'll keep on speaking about esophagus because that is the heart of my journey. And in esophagus, most even today, surgeons talk about whether two-field lymph node dissections to be done or three-field lymph node dissection to be done. So aggressive lymph node to be addressed or not at the time of performing esophageectomy. Now, in the absence of intraoperative nerve monitoring, in the absence of articulating instrument, if we try and perform that lymph node dissection along the recurrent laryngeal nerves, then there will be some paralysis or injury to the nerve, and that will give rise to lot of problem to the patient. And because of those problems, surgeon will not perform those surgery. See here, because of the lack of safety, we are not pursuing cancer surgery aggressively. The moment we are talking about safe procedure, everyone is happy to perform that surgery, going extra mile and to help the patient. So this is how things are. So this is something which we have also encountered in our practice. In last 15 years, we have become much more courageous in performing this surgery, going that extra mile, take out that extra lymph node basin so that we can stage our patient aggressively. We can make sure that even if there is 2 foci in that recurrent laryngeal lymph node basin, that will be taken out and that patient will be benefited. And certainly, when I was student in 2006 to 2013, in that 8 years, these were the major procedures which were not performed at most of the centers. With when we were taking consent, we were explaining to our patient that risk is around 15%, 20%. Now that number has gone down to 2%. So certainly that,
Yeah.
and so we have democratized. Earlier, these procedures were performed at very selected centers, but because of the advent of availability of this technology at multiple places and talent, I'll say there is no lack of talent. India is very rich in terms of
Yes.
talented surgeons and youngsters.
Yeah.
uh, now so many tier 2, tier 3 cities are also performing these procedures with utmost safety. So that's the real win for us.
Yeah.
So learning and learnability both has gone up.
Yeah. Thank you. Thank you so much.
Sir, you are mute.
Dr. Nalini, I want to add 2 points here. One, the question you asked about the cost factor. Let me mention one thing that against the safety and security of the patient. Sometimes we just ignore the cost factor because ultimately it's about saving the precious human life. So maybe 50,000 or 70,000 when we're spending 5 days or more than 5 days, 50 or 70,000 exam for or not. While considering the safety and security of the surgeon, for safety and security of the patient, that is one. And I would like to add a very important point. What Dr. Kali said few minutes back, it is all about learning, relearning, and the important part, what Dr. Mehta said, that Indian oncologist, the exposure are having in OPD or OPD is enormous. I mean, you have to need to monitor the patients and everyone
Shrenik
that
sir,
unless you don't
sir,
have
your
a
voice is
fancy
not
or
clear.
technical.
Shrenik sir, your voice is not clear.
Sir, point is very well taken. Hello.
Go
Sir,
ahead,
I think
Dr.
it's
Parik.
Shrenik sir.
Yes. So, as Renny Bhai was saying, that ultimately, when we talk about safety versus some additional cost in longer run or in major cohort, so when for 1 or 2 patient, uh, it may be not comparable. But if we take cohort of 100 patient or 1,000 patient, then certainly, when we talk about a safe environment for patient, that will always win over the little bit of extra cost.
Yeah, that's true. Safety is very important.
And especially in cancer patient where they need to take multiple treatments. So sometimes treatment lasts for as long as 6 to 8 months, where if there is untoward event at one point, then entire treatment, this thing will be disturbed. These are very
So,
common
Dr.
questions.
Parik, may
Please,
I come in? Can this become the standard of care
it has
for a
already
cancer?
become the standard of care, ma'am. It has already become the standard of care. Now, if you see the guidelines, be it ISMO guideline, Japanese guideline, or NCCN guidelines, they have put on paper that these are the standard of care treatments earlier. So 10 years down the line, they were comparing. So now there are randomized control trial to back this treatment. If we see the roller trial, which has compared conventional laparoscopic surgery versus robotic assisted surgery, they come up with the answer that in male obese patients, narrow pelvis, robotic is superior to laparoscopy when we talk about sphincter sparing resections. Similarly, when we talk about esophageal cancer surgery, there are time trial and some other trials which are literally saying that these minimal access procedures are far superior to conventional procedures. Here, there are so many recoveries apart from surgical outcomes in terms of patient's ability to eat again. There are respiratory reserves, respiratory complications which we talk about in esophageal cancer surgery, and they are far superior when we talk about minimal access procedures. So yes, it has become standard of care. So at our center, I'll talk about my center, my personal experience. Uh, we started this in 2016 till 2019 1920, we were giving options to the patients that open surgery, robotic surgery, laparoscopic surgery, or thoracoscopic surgery. These are the options. In 2018, 1920 onwards, we have stopped giving option of open surgery. So there are no open surgeries. Minimal access surgery, either thoracoscopic surgery or robotic surgery. And now 2023-24 onwards, now we are more and more inclined towards robotic surgery. So earlier we were like operating 30 robotic cases, 70 conventional treatments, conventional surgeries. Now that number of 30 has gone to 90. So out of 100, 90% of our work is now robotic surgery, especially when we are talking about thoracic cancers.
Very commendable. And you all have published some
So
studies on this?
I'll be very happy to share that I presented my work to Japanese Society of Clinical Oncology in 2019, from where I learnt my this minimal access esophageal cancer surgery training. And again in September 2020-26, I'm going to Kyoto for ISD, that is International Society for Diseases of Esophagus, where I am presenting 3 papers.
Wonderful.
It's really good. Which is the other this thing, let's say organs that you all do apart from thoracic and lung and esophageal? Which are the others that you all do which are very successful?
So as I shown in my slides, at our center, most commonly performed robotic surgeries are for urological cancers. So partial cystectomies and prostatectomies, radical prostatectomies, and partial nephrectomies as well. So for most of the urological cancers, robotic surgery has become standard of care, and that is across the globe. So when I talk about my center, it certainly is practiced everywhere in India and elsewhere in the world. Apart from that, colorectal cancers. Colorectal cancer is again a specialty where robot has a great influence. Third is HPB. HPB, all procedures are major, be it liver resection, be it Whipple's procedures. And as I said, in major and complex procedures, influence of robotics is immense. Apart from that, very commonly used specialty for robotic is gynae onco. So I'm talking about oncology because I'm a cancer surgeon. Gynae onco is also one specialty where it is coming up in a very big way. Most of the gynae onco surgeons are very comfortable and inclined to use robotics in their practice day in day out. It is coming in very specific areas of head and neck cancer as well. So these are some of the specialties where robotic is now used day in day out.
Dr. Manik, one question since you mentioned about specific or organ specific surgery. What is the role of robotic assisted surgery in case of neurological disorder or brain tumor?
Uh, Sir, so I'll say in this way that this technology, minimal access robotic surgeries are very apt for the areas where there is a cavity. So like abdominal cavity or thoracic cavity. Whenever there is a cavity, then we'll be able to apply this technology because of their instruments, their pods, their arms. We need some working area where we can actually work. Now, brain related surgeries are some places where there is a actual positive of cavity. Entire of the cavity is used or occupied by the brain. So in neurological cases, I'm not a neurosurgeon, so I'm not a right person to comment about any neurological treatment, but still there is a positive treatment as far as neurology is concerned with the help of robotics.
Thank you. Anyone like to ask Dr. Priyabar if you want to ask?
Pardon, sir?
Shrenik, I have asked my
I am
question
one of
from
the
Dr. Parekh.
colleague and director Indian Cancer Society.
I've already asked him, and we look forward to his doing a very successful and a standing ovation in Japan when he presents his cases.
Thank you, ma'am.
And this was a very good learning for us also, Dr. Parekh, I don't think robotic surgery is covered under Ayushman Bharat. So the poor
So
patient will not be getting access to it.
at Ahmedabad in Gujarat,
Uh-huh.
our patients at GCRI, that is Gujarat
Hmm.
Cancer and Research Institute,
Mhm.
now they have started covering robotic surgery for cancer patients. So they have received their robot as late as last year only, but now they have started with robotic surgery under Ayushman card. But at our center, we are not supporting that schemes, government scheme.
Ayushman, yeah, yeah.
Ayushman, yes. But again, at all major hospitals, like I have personally visited Tata Memorial Hospital, AIMS Delhi, AIMS Jodhpur, AIMS
Hmm.
Rishikesh, AIMS Patna, all these major institutes have robots, and they are supporting their government beneficiary patients for their surgeries, and they are doing it with robotic assisted surgeries.
So that's very heartening to hear that, considering that you are such a strong advocate for robotic surgery and better patient outcomes.
Absolutely, it's government's responsibility to increase their healthcare expenditure and support the patients when they are in need. Every patient shall receive standard of care treatment. They shall not be denied of treatment, especially when safety is of paramount importance.
Very true, Dr. Parekh. Shrenik, are you there?
आई थिंक मैम शेनिक सर का ना फिर से नेटवर्क इशू हो गया है तो ही इज नॉट हियर.
Nalini, do you have any queries, Dr. Nalini?
No. I think Dr. Parekh has given us a very detailed account of robotic surgery. And I think, as you said, we have learned a lot from this. We used to always hear about it, but you've given us these videos as very explained it very well. Yeah, thank you.
Thank you,
And
ma'am.
most important, Dr. Parekh, from a CSO perspective, is when doctors stand completely with the patient, irrespective of their economic status. And we really liked your last line where you said that all patients have a right to standard of care,
Absolutely,
irrespective
ma'am.
of the cost, and it's a government's duty. So that's something which, we identify very strongly as a CSO. And we are so
Absolutely.
happy to hear you advocating it. I wish more doctors could come out and start doing this. You all will bring about the policy change once the
Absolutely.
policy makers
And
do it.
if I may add, it's not only government's duty; it's duty of society as a whole. So at our hospital, our center, we have started a foundation which is supporting uh, some of the patients who are needy, and they are, because of their financial constraint, not able to receive such treatment. We support them. So, as a hospital, as a clinicians, we also want to play our role to support patient financially, so that they can go that extra mile and receive such state of the art treatments.
Which is very true. So, Dr. Parekh, your time is very precious. Thank you very much for giving us time
Thank
and
you, thank you,
educating us. It's been a real pleasure hearing you. And I think all of us would like to thank you for that.
thank you.
Thank you so
Yeah,
much. Bye.
yeah, you did good job on behalf of me. I mean, somehow I'm having, unbearable network issue. I'm getting disconnected frequently. I don't know why. But anyway, Dr. Parik, thank you so much. Let's catch up. I mean, we have never met earlier, but let's catch up over a coffee in the next week at a
Certainly,
mutual convenient time. Friends,
definitely.
thank you so much, Dr. Nalini, Vanna, Sangeeta Ji, Sandhya Gupta, Dr. Priya, Sneha, and everyone. Thank you so much. And Dr. Manik, thank you so very much for
Thank you,
your,
thank you,
commendable talk with the presentation and answering all questions satisfactorily. Thank you so very much. Have a great day
thank
and
you.
bye bye. Bye.